Today we'll study acute lymphoblastic leukemia or ALL. What is ALL? ALL is basically neoplastic proliferation of precursor B cells or precursor T cells. So if it is a neoplastic proliferation of precursor B cells, we call it BALL or B acute lymphoblastic leukemia or pre-B acute lymphoblastic leukemia. But if there is neoplastic proliferation of precursor T cells, we call it pre-T acute lymphoblastic leukemia or precursor T cell acute lymphoblastic leukemia. So after knowing the definition of acute lymphoblastic leukemia, we'll go into it. So in BALL or B cells acute precursor B cell acute lymphoblastic leukemia, pre-BALL, it involves the precursor B cells, that this cell, this initial cell or this precursor B cell is involved in pre-BALL. So it is developing in the bone marrow, whereas in pre-TALL, the cell which is involved is a precursor T cell. So in pre-BALL, the cell which is involved is a precursor B cell, whereas in pre-TALL, the cell which is involved is the precursor T cell. So this precursor B cell is developing in the bone marrow, whereas precursor T cell is developing in the thymus. So as precursor B cell is developing in the bone marrow and the precursor B cell, the amount of precursor B cell is maximum, means that the amount of precursor B cell is maximum in the body in the childhood. So this disease pre-BALL or precursor B cell ALL, it mostly occurs in childhood or peaks at 3 years of age. Why? Because the amount of precursor B cells, is greatest in the childhood or 3 years of age. But in precursor T cells, it peaks at adolescence. Why? This precursor TALL, it peaks at adolescence. This is because the thymus, because as these precursor T cells or T cells are developing in the thymus, and thymus reaches its maximum size during the adolescence, since this disease peaks at adolescence. Okay, another thing about this pre-BALL or pre-TALL is that this precursor BALL, it presents as a leukemia. Precursor BALL mostly presents as leukemia, whereas precursor TALL, it mostly presents as a lymphoma. So why is this so? As we know that these precursor B cells, they are now malignant and they are neoplastic. So these precursor B cells, they will undergo a lot of mitosis and they will fill the bone marrow. And after filling the bone marrow, they will spill into the circulation. So hence this pre-BALL will give us a leukemic picture. But precursor TALL or pre-TALL, in this the precursor T cells are only dividing and they are only increasing in number in a thymus. Hence it will give us thymic masses. So now going towards the pathogenesis of this disease, that how it occurs. So when we are studying pathogenesis, we should have an idea very clear in our mind that precursor B cells, or precursor T cells, they finally transform into either mature B cell or mature T cell. So the end result of these lineages is that there will be either B cell formed or a T cell formed. So for this step-by-step maturation, or for this step-by-step development, we need certain transcription factors. For this step-by-step development, we need certain transcription factors. And these transcription factors are necessary for the development of precursor B cells or precursor T cells finally into B cells or T cells. Certain transcription factors are necessary for the development of precursor B cells or precursor T cells into B cells and T cells respectively. But if there is a mutation in these transcription factors, the pre-B cells and pre-T cells, they will not be able to form B cells and T cells respectively. Why? What kind of mutation will be there? Loss of function mutation or gain of function mutation? Exactly, loss of function mutation. If there is loss of function mutation of these transcription factors, that the transcription factors are not able to function and they are not able to function properly, what is the normal function of these transcription factors? The normal function of these transcription factors is to mature these precursor B cells, is to develop these precursor B cells and precursor T cells into B cells and T cells respectively. But now these transcription factors are not working properly because they are mutated. And what kind of mutation is there? There is loss of function mutation in these transcription factors. So we will have a lot of these precursor B cells. Mean that these precursor B cells, they will not develop properly and they will increase in their number. So and they will dump here into the bone marrow. The precursor B cells are dumping into the bone marrow. Whereas precursor T cells, they are dumping into the thymus. But do you think that this single mutation or this one mutation can lead to a full-blown cancer? No. There are about less than 10 mutations which are required to develop a full-blown acute lymphoblastic leukemia or lymphoma. So we will not study all of them, but we will study important mutations of them. So what are other mutations that are involved? So this only transcription factors mutation cannot drive a full-blown cancer. So we need other mutations as well. For example, we need RAS mutations, or we need certain tyrosine kinase mutations. That is, we need certain mutations that make our RAS and that make our tyrosine kinase independent of the growth factor stimulus. That even without growth factors, this RAS and this tyrosine kinase will be able to give oncogenic stimulus. So how these mutations occurs? These mutations occurs by either there are two types of mechanisms for this mutation. Either we will have numerical mutations, or we will have structural mutations. Either we will have numerical mutations or we will have structural mutations. So what is the difference between numerical mutation and structural mutations? Numerical mutations means that there will be either increase than the normal number of the chromosomes, or there will be either decrease than the normal number of chromosomes. And what is structural mutations? Structural mutations, that either there may be some deletions in the chromosomes or there may be some translocations in these chromosomes so that the structure of the chromosome is altered. So in this case of ALL, these numerical mutations can be of two types. They can be either hyperploidies, or they can be either hypoploidy. So these numerical mutations can be either hyperploidies or they can be either hypoploidies. But what are structural mutations? Structural mutations are either balanced translocations. These are either balanced translocations or deletions. So hyperploidy 51 is a very common mutation. Hyperploidy 51 is a very common mutation, whereas hypoploidy is also there. Also, we know that this hyperploidy is associated with a good prognosis. Whereas hypoplasty is associated with a bad prognosis. So if we are having numerical mutations, they can be either hyperplasty or hypoplasty in the case of ALL. So hyperplasty is associated with a good prognosis, whereas hypoplasty is associated with a bad prognosis. Whereas, what are the structural mutations? Structural mutations can be either balanced translocations or deletions. So now I'll tell you that what kind of balanced translocation can be there. We'll have two types of balanced translocations. One is one balanced translocation is 9-22 translocation. And you know that this 9-22 balanced translocation is almost always associated with chronic myeloid leukemia or CML. But this 9-22 translocation is also seen in acute lymphoblastic leukemia, in some of the cases of acute lymphoblastic leukemia. So what happens when there is 9-22 balanced translocation? So in this chromosome number 9, we are having a gene that is known as ADL. Whereas in this chromosome number 22, we are having a gene that is BCR. So what happens that this ADL shifts from the 9 chromosome to the 22 chromosome and it attaches to the BCR gene. So the gene that is, the chromosomes that are found are somewhat like this. So these are our new chromosome formed. So this ADL gene shifts from the 9th chromosome to the 22nd chromosome, and here this ADL gene attaches to BCR. So there is a formation of a fusion gene and this fusion gene is BCR ABL. This fusion gene will then produce a fusion protein, and this fusion protein is known as a chimeric protein. This fusion protein is a chimeric protein which is having both BCR and ABL. So we have a new protein formed, and this is a chimeric protein, and this chimeric protein is a fusion protein of both ABL and BCR. Now what was the normal function of ABL? The normal function of ABL was that when it was stimulated, it forwarded growth signals. That when this ABL alone, when it was stimulated, it transforms or it gave growth signals, pro-growth signals. But what was necessary for this growth signal? The necessary thing was to stimulate ABL. But now, after this BCR-ABL fusion, this BCR-ABL is perpetually activated, and there is no signal needed for its function, and it will be perpetually giving growth signals. That there is no stimulus, but this BCR-ABL will give growth signals or proliferative signals without any stimulation. That is, there is no growth factor present, but this BCR and ABL, they will forward growth signals, and this cell will over-proliferate as a result. And now, after this over-proliferation, we'll have another thing, that initially these cells were not developing initially due to this transcription factor mutation. Due to the loss of function of these transcription factors, these precursor B cells or precursor T cells, they were not developing into the mature cells. So these precursor B cells and precursor T cells, they were increasing in number. But now, as there is some mutation which is giving growth signals, and these growth signals are independent of growth factors. That is, independent of growth factors, we are having growth signals. So there will be a lot of divisions of these precursor B cell and precursor T cell. That is, these precursor B cells and these precursor T cells, they will over proliferate. and as a result we will have our bone marrow overcrowded. Along with this overcrowded bone marrow, we are also having our thymus overcrowded. So this overcrowded bone marrow or this overcrowded thymus, they are as a result of two types of mutation. Either there are transcription factors mutation, and also there are some other mutations, and these other mutations are leading to overproliferation. There is another translocation which may also be there, and this second translocation is not 9-22 translocation, but it is 12-21 translocation. 12-21 translocation also result in the formation of a chimeric protein, and this chimeric protein is an aberrant or mutated transcription factor. So, as I told you earlier, that there is initially a transcription factor mutation. So, this transcription factor mutation results here as a result of 12-21 translocation, and as there is 12-21 translocation, we will have an aberrant transcription factor, and this aberrant transcription factor will result in lack of maturation of precursor B cells and precursor T cells. We are having a hypercellular bone marrow, and as a result of this hypercellular bone marrow, these cells will also dump into the circulation. So as these cells will dump into the circulation, we will have leukocytosis, and the WBC count will be raised. So our complete blood count, the WBC count will be raised. But these WBCs, they are abnormal WBCs. They are not B cells or T cells. They are precursor B cells, or they are precursor B cells most commonly. So as the WBC count is increased and these WBCs are non-functional, so what will happen next? As a result, the bone marrow, this bone marrow is overcrowded by precursor B cells. So the normal function of the bone marrow will be lost, and there will be features of bone marrow failure. So the normal function of the bone marrow is lost, and we will have features of bone marrow failure. So what is this bone marrow failure? In bone marrow failure, the function of the bone marrow is disturbed. And what is the normal function of bone marrow? The normal function of bone marrow is to form neutrophils, is to form other cells like red blood cells, is to form cells like platelets. So these cells will not be able to form, and as a result, we will have neutropenia. We will have thrombocytopenia, and we will have less RBCs or anemias. So, what is the clinical picture? That as a result, we are having leukocytosis, but this leukocytosis is formed of immature blast cells, and there will be features of bone marrow failure, and as a result of this bone marrow failure, we will have neutropenia, and we will have thrombocytopenia, and we will have anemia. So, what are the features of neutropenia? The features of neutropenia is that this person will be prone to infections. Because of neutropenia, that is the neutrophil count is low, this person is prone to infections. What else? Because of anemia, this person will be fatigued, and because of thrombocytopenia, this person will develop bleeding tendencies. So it is the clinical picture of this patient. So as these leukocytes and these immature leukocytes they are dumping into our circulation. They are dumping into our circulation, blood circulation. They will also travel towards our liver. They will also travel towards spleen, and they will also travel towards lymph nodes, okay. So as a result, as these immature, these neoplastic cells, they are traveling towards liver and they are settling there. They are also traveling towards the spleen and they are also traveling towards the lymph nodes. Why are they settling there? They are settling in the lymph nodes, in the liver and in the spleen, because they were initially, during the embryonic life, these cells used to develop in the liver and in the spleen and in the lymph node. The hematopoiesis used to occur in these cells. So immature precursor B cells, they have a tendency to reside in the liver, spleen and lymph nodes. So as a result, we will have hepatosplenomegaly, and lymphadenopathy. So we are having hepatosplenomegaly and lymphadenopathy. Also, this bone marrow is increasing in the bone marrow is increasing in size. That is, the bone marrow is hypercellular. As this bone marrow is hypercellular, these cells will infiltrate the periosteum of the bone, and as they will infiltrate the periosteum of the bone, so we will also have bone pains, bony pains. What else? So these immature or these precursor B cells or these neoplastic cells, they will also reach our central nervous system. And here in the central nervous system, our cells will irritate our meninges, and this condition is known as meningism. So due to the CNS involvement, we will have headaches, vomiting, etc., or nausea, and other CNS manifestations. And this condition is known as meningism. So these are certain clinical features, and others will also have other features that are related to neoplasm, that will have weight loss, etc. So now I will tell you about the morphology of acute lymphoblastic leukemia. So in the morphology, we are having a hypercellular bone marrow, or we are having a hypercellular thymus, and this thymus is enlarged thymus. So if we look at these cells in the microscope, so under the microscope we will be able to see certain cells, and these cells are like this. And here will be a central nucleus, and in this nucleus we will have a nucleolus, and we will also have fine chromatin. So we will have a nucleus and fine chromatin inside it, and also a nucleolus, and the cytoplasm will be scanty. So we will have to, so cytoplasm is scanty, so we will have to just, we will have a scanty basophilic cytoplasm. So we will have a scanty basophilic cytoplasm, that it will stain blue in color. So in pre-BALL, if we are having hypercellular bone marrow, and now if we are looking under a section of a bone marrow in a microscope, the B cells or these precursor B cell or these malignant B cells, they will look like this. They will have a scant they will have a scant cytoplasm, and it will be basophilic, and also they will have fine chromatin, and along with this fine chromatin there will be a nucleolus. So these precursor T cells and precursor B cells, they will look the same. Also, if we want to differentiate this condition from an acute myeloid leukemia, and this in acute myeloid leukemia, the cells are also similar. The cells of acute myeloid leukemia are also similar. They are also having a fine chromatin, they are also having a nucleolus, and they are also having a basophilic cytoplasm. So how will we differentiate the cells of acute lymphoblastic leukemia from the cells of acute myeloid leukemia? So we will differentiate them on the basis of staining. So what kind of staining are there? This cell, the cell of acute myeloid leukemia, is positive for myeloperoxidase, MPO positive, whereas our cells of acute lymphoblastic leukemia, or this lymphoblast, it is negative for myeloperoxidase. But this cell is positive for this lymphoblast. This lymphoblast is positive for TDT, whereas this myeloblast is negative for TDT. Under the microscope, in this myeloblast, we also see certain hour rods, and these hour rods are the aggregation of myeloperoxidase. But here in this lymphoblast, we cannot see hour rods because there is no myeloperoxidase present. So now, if we want to differentiate this acute lymphoblastic, the precursor B cell acute lymphoblastic leukemia from precursor T cell acute lymphoblastic leukemia, we will have to focus on immunohistochemistry. Now we are differentiating this precursor T cell acute lymphoblastic leukemia from precursor B cell acute lymphoblastic leukemia. So we will do it by means of immunohistochemistry. So this precursor B cell acute lymphoblastic leukemia, or this precursor B cell acute lymphoblast, this will have precursor B cell markers. And what are those precursor B cell markers? This cell will have this B lymphoblast, pre-B lymphoblast. It will have PAX5 marker. It will also have CD19 and CD10. Whereas this precursor T cell lymphoblast or pre-T lymphoblast, it will have CD1, CD5, CD7 and CD9. Then it will have precursor T cell markers. This is we can differentiate them on the basis of immunohistochemistry, and this is a T cell lymphoblast. This is precursor T lymphoblast. So now, after this immunohistochemistry, we'll move toward the prognosis. So what are certain prognostic features? So I have told you some of them earlier, that if there is hyperploidy, so we will have a good prognosis. So we will differentiate this prognosis, that either there is a bad prognosis or a good prognosis. So the markers of good prognosis are hyperploidy, whereas one of the markers of bad prognosis is hypoploidy. Also, 12-21 translocation. 12-21 translocation is a marker of a good prognosis, whereas 9-22 translocation is a marker of poor or bad prognosis. also. Another marker of good prognosis, age between 2 and 10 is a marker of a good prognosis, but age of less than 2 and greater than 10 is a marker of poor prognosis. Another marker of prognosis is that even after good chemotherapy, you are having certain neoplastic cells. Even after good chemotherapy, you are having certain neoplastic cells. So this is a marker of bad or poor prognosis. So it was all about acute lymphoblastic leukemia. Hope you like the video. Subscribe our channel and give us a thumbs up. Thank you.